Hello, everyone from THT 2026. My name is Jason Katz. I'm an advanced heart failure, transplant, and critical care cardiologist at NYU Grossman School of Medicine and Bellevue Hospital. I'm here with Tony Carnicelli. Tony and I are both part of the leadership team of the new Journal of Cardiac Failure Intersections. Tony, if you wouldn't mind introducing yourself.
My name is Anthony Carnicelli. I'm an associate professor of medicine at Medical University of South Carolina and an advanced heart failure cardiologist. It's a pleasure to have an opportunity to chat with you about some interesting research.
First, let's talk about the RAND appropriateness panel that you were a part of, that you helped co-lead on the heart failure cardiogenic shock space. You know, in reflecting on that experience, what were some of the most striking differences of opinion amongst this international expert panel, and what does that tell us about the future priorities of our field?
Yeah, a great question and an amazing study run by Dr. Proudfoot. The RAND appropriateness design is really interesting, where experts internationally are gathered to basically fill out a survey and then discuss a number of different facets of, in this case, heart failure, cardiogenic shock. And the discussion was actually one of the most fun parts of this study, is just to learn about other practices in other countries around the world and how there's so much more to learn and investigate. I think one of the more interesting things, I guess, from each domain, there was the diagnostic domain in cardiogenic shock, the mechanical circulatory support domain, and then the weaning or de-escalation domain, I should say. And some of the disagreements that I thought were most interesting were, there was a fair amount of disagreement about the use of point-of-care ultrasound. Some folks felt passionately about its role in the diagnosis and treatment of cardiogenic shock, and some folks felt dispassionately about it. There was interesting debate and discussion about pulmonary artery catheters as well. And obviously, that's a long-standing question and issue, is the role of PA catheters in heart failure and in cardiogenic shock. But still today, in 2026, or at the time we published that in 2024, there's still debate or unanswered questions about the role of PA catheters in shock and using various different hemodynamic thresholds to escalate or de-escalate care. One of the things I really enjoyed talking about was the mechanical circulatory support part of things. And as you may imagine, there was a fair amount of disagreement about the role of intra-aortic balloon pump and microaxial flow pumps in specifically heart failure shock. With actually the intra-aortic balloon pump piece was probably the part where there was the most disagreement. And not just sole TMCS or intra-aortic balloon or microaxial flow pump, there was a lot of disagreement about using these devices as an upfront venting strategy in patients with VA ECMO too, which is, again, very interesting because we have some fair data to support venting and LV venting in VA ECMO. And then there was a reasonable amount of disagreement as well with regard to pharmacologic weaning strategies. Of course, levosimendan came up, being an international panel, and I'm certainly not a levosimendan expert, but there was a fair amount of disagreement about the role for select patients in cardiogenic shock. So it was a phenomenal discussion and really highlighted a lot of the opportunities for further investigation as we move forward in the field.
Second question for you, and let's stick with the differences theme here. We're talking about heart failure cardiogenic shock. We know a lot, probably even more, about AMI cardiogenic shock, and what we certainly know is that the outcomes of patients who experience AMI versus heart failure cardiogenic shock are different, and we talk about these differences. When you think about that, what are some of the differences, either in outcomes or management strategies, that probably aren't getting enough attention?
As you mentioned, we know a lot about AMI shock, and that's a fortunate place to be in. And thanks primarily to our European colleagues, they've really populated the literature with some phenomenally run mechanical circulatory support trials in AMI cardiogenic shock. We know the outcomes in AMI shock are worse, as you mentioned. Heart failure shock, though, represents a large majority, in fact, of the cardiogenic shock we see, and it still is this black box with regard to the role of MCS and MCS device therapy, escalation weaning, et cetera, and specifically role as a bridge to an exit, bridge to advanced heart failure therapies. At the time we published the RAND analysis, we hadn't had the ULT-SHOCK-2 trial, and so I'm not sure if the RAND analysis would have actually changed had we known the results of the ULT-SHOCK-2 trial. But For me personally, I think one of the most interesting aspects in which we need to address this larger question as a field is, what is the role of MCS, of temporary MCS in heart failure cardiogenic shock? Is it an early MCS strategy? Is it preferential to use higher capacity microaxial flow pumps? Should we be avoiding intra-aortic balloon pumps, or are they actually a reasonable bridge to decision? Should we do everything possible to avoid multiple mechanical circulatory support devices? And for those in whom MCS is utilized, how do we reduce the risk of complications? Because that's actually one of the most important things that we can do in medicine. Of course, first, do no harm to these folks. So to me, again, personally, the role of mechanical circulatory support in heart failure cardiogenic shock is one in which there is an enormous opportunity for research.